And here we go. The autonomic nervous system. I've been talking about this since day one. Autonomic nervous system. Come on. You got the parasympathetic branch, which is mostly motor, of course, and sympathetic. And I'm always eating a burrito when this happens, right? When the bear comes out, this is when the bear comes out, and this is the burrito. I don't know if I spelt that right. Natalia, is there one R? Que pasa? So parasympathetic, rest and digest. So you're digesting a burrito. Heart rate is slow. Your blood pressure is low. Your respiratory rate is slow. Sympathetic is just the opposite. Stop digesting. Increase blood flow to your brain, to your skeletal muscles, in case you want to decide to run away or fight the bear. All right. So remember the effectors. I talk about this a lot. I probably said this 1,000 times. But the effectors for the ANS are your heart, which of course is cardiac muscle. Because you'll get questions on this departmental practice exam final about different muscle. Cardiac muscle is one of the effectors for the ANS, of course. Smooth muscle is in your blood vessels, the tunica medius. Of course, you didn't learn that. Yeah, that's an AP2, but you should know that what smooth muscle is also called visceral, part of organs, digestive, blood vessels, reproductive. Cardiac muscle is heart muscle. Remember the intercalated discs. I guarantee you get a question about that. And the third effector for ANS is glands, like the adrenal gland, sweat glands, and hormone-producing glands, really. And digestive glands, too, because remember, parasympathetic increases digestion. Sympathetic stops that. Tear glands, right, lacrimal glands, and all that stuff. So remember the neurotransmitters. To the effector, though, to the effector, like the parasympathetic to the effector is always acetylcholine. The neurotransmitter to the effectors in the sympathetic nervous system is always norepinephrine, or epinephrine, adrenaline. It's all the same thing as a neurotransmitter. The only time the sympathetic releases something else besides norepinephrine to an effector is sweat glands and sympathetic stimulation. So technically that's one contradiction or one exception to the rule that the sympathetic nervous system post-ganglionic neurons will release acetylcholine to the sweat glands. So that's pretty much what this whole thing is about. So it's mostly motor, right? There is afferent too. There is afferent because you have to get a signal into the ANS some way, especially the medulla oblongata, right? So again, smooth muscles, cardiac muscle, and glands are the effectors. Remember the somatic nervous system, the effector is skeletal muscle. So again, know the differences between those three muscles for your departmental final examination. Yeah, so it's all about homeostasis, making adjustments to things like your heart rate, your blood pressure, your respiratory rate, digestive. Remember, you're mixing parasympathetic and sympathetic because they're both autonomic. And it's not voluntary, subconscious, involuntary. You don't need your cerebral cortex for this. It's all happening in the brainstem, mostly the brainstem, deep part of the brain. Remember the medulla oblongata, the pons, and the midbrain. And it's very visceral. Visceral means more organs, not somatic. Somatic is your skeletal muscle and your sensory receptors for somatic senses. I would memorize this. I would definitely memorize this. If I was Ryan, I would put this as a screensaver on my cell phone and just make sure you know the branches because it's simple questions like ordering. You don't want to lose points for this. All right. Congratulations to Ryan. He was a star on my lab practical. I didn't mean to call you out, but I'm so excited for you. Now, this the ANS. Yeah, you got it, buddy. The ANS versus the somatic nervous system. Don't get this confused. Don't ever say SNS because that's all screwed up. That'll make you think it's sympathetic. Don't say that. Somatic versus autonomic. Get it? You got it. So you have different effectors. I told you that 1,000 times. So you should know that. Efferent is motor. Right? Ganglia is, remember this, are cell bodies, groups of cell bodies, and technically axon terminals in the PNS. In the CNS, group of cell bodies and axon terminals are called nuclei. Yeah. So let me draw. This is, watch this. This is a beautiful neuron. But you wouldn't even find this in the Hall of Science. So this is a, like say this is the CNS, right? This is the CNS here, like the spinal cord of the brain, right? So the cell body is here. And this is a motor neuron, efferent. It's coming out of the CNS, right? And it's got axon terminals. These are axon terminals. You could imagine this. Come on, this is going to be at the Whitney Museum by Sunday, right next to the Georgia O'Keeffe's. So now, right here, you have another neuron that's going to go here, right? And it's got axon terminals and a cell body. So right here, outside the CNS, you have a group of cell body and axon terminals. And it's gray matter because there's no, the myelin is out here. Remember myelin and the node of Ranvier? They're not always myelinated, though, these autonomic fibers, but that's neither here nor there right now. But I want to teach you that this is a ganglia. Ganglia. What is a ganglia? It's a group of cell bodies within the PNS. So this is all PNS, right? Along the spine or near the outside of the midbrain or the brainstem, sorry. So this is an autonomic ganglia where you have this is called, watch this. If you get this, you're really ahead of the game. This neuron right here, now remember, this is efferent coming out. And say the effector is the heart, right? So this neuron right here is called the, guess what? Preganglionic neuron. And of course it has a membrane, all that stuff. This is the postganglionic neuron. And where's it going? To an effector, like the heart, like the SA node. We don't really know what the hell an SA node is, but you'll know the next semester. That's where the action potentials start for the heart to cause depolarization. But it also, can go to the heart muscle too. Depends if it's sympathetic or parasympathetic. So this could be parasympathetic or a sympathetic pathway. So you have nuclei in the CNS. I'm gonna write that down. That's called nuclei. Autonomic nuclei. You get it, because nuclei is a group of cell bodies and axon terminals within the CNS. It's gray matter. You get it? You got it? Good. Right, so just to review, how many times do I have to say this? And you're going to get this right. Turner, you're going to get this right every time. Somatic nervous system targets skeletal muscles and motor. Those are the effectors. Autonomic, sympathetic, and parasympathetic, cardiac muscle, which is only one place in the heart. Smooth muscle is like in blood vessels or the liver or the stomach or pancreas. See, these are beautiful drawings. And then the glands, right? Like your digestive glands and like this perfect gland right there, your sweat glands, all of that. I'm not saying that anymore. So now what are we talking about? Efferent pathways and ganglia. So again, cell bodies, thick myelinated group A axons extend to the spinal or cranial nerves directly to skeletal muscle. So this, they're saying somatic. You know this from muscle. And there's a couple of cranial nerves. There's one cranial nerve, I'm sorry, that innervates a skeletal muscle. Remember cranial nerve 9, I'm sorry, cranial nerve 11. Cranial nerve 11 innervates the trapezius and the SCM, sternocleidomastoid. But you could say SCM on the exam, don't worry. So cranial nerve 11 will innervate a skeletal muscle. So again, we're talking, we got to get here. Let's talk about this. So you have a preganglionic neuron, which I showed you. I drew that beautiful picture. And the cell body's in the CNS, therefore it's a nuclei. And the preganglionic axon goes to the ganglion, which I drew. Now the next neuron is a postganglionic neuron. So its cell body is in the ganglia because it's in the PNS, it's outside the CNS. And that's an autonomic ganglion. And usually it's non-myelinated postganglionid axons. Usually, not always though. Not always. This is going to be a good picture coming up, hopefully. Not as good as mine. So in the somatic nervous system, let's just keep comparing. Why not? In the somatic nervous system, to the effector, the release is always acetylcholine. And it's always excitatory to the muscle for muscle contraction. Always, right? And the autonomic nervous system, and this is what you gotta wrap around your head right now. Remember the preganglionic neuron? I'm gonna draw it again. In the CNS, the preganglionic neuron, in both sympathetic and parasympathetic autonomic, always releases acetylcholine. That means this postganglionic neuron always has receptors for acetylcholine. And that's a ganglion. That's an autonomic ganglion. It doesn't matter if it's parasympathetic or sympathetic. These receptors are always cholinergic. You're going to hear a word called cholinergic. When you hear cholinergic, that means the receptor, and these are receptors, is for acetylcholine. And there's two types of cholinergic receptors. And I'll just tell you. One is called nicotinic, and the other is muscarinic. 99 or more or less, around there, 99% of the time, these receptors are nicotinic cholinergic, and they're always for acetylcholine. So I don't care. Even in the adrenal medulla, this preganglionic neuron is releasing acetylcholine. It's the effector neurotransmitter that changes, except sweat glands. So for the parasympathetic, the postganglionic neuron will be releasing acetylcholine to save the heart, right? To slow down the heart rate. The sympathetic postganglionic neuron will release norepinephrine, and that'll speed up the heart rate. So now the receptors, there's two types of receptors on the heart, say. One is cholinergic for the parasympathetic, and usually that's muscarinic. Now, whenever you hear nicotinic or muscarinic, that's cholinergic. So it has to be for acetylcholine. Now, the receptors for norepinephrine, say, are called adrenergic. Adrenergic. Because it means adrenaline, right? So these are receptors. Receptors. And we're going to go over this again. Because this is probably one of the most difficult things in this chapter, is to understand pre and post ganglionic neurons and the receptors, cholinergic versus adrenergic. But listen to me, you're recording this. Cholinergic is only acetylcholine. Two examples of cholinergic receptors are nicotinic and muscarinic, always for acetylcholine. So all you got to remember now is that what's the receptor for norepinephrine or epinephrine or adrenaline? And those are adrenergic, and they could be beta or alpha. So the ones on the heart happen to be beta 1. I always remember because there's only one heart and there's two lungs. So beta adrenergic receptors on the heart are beta 1, and the lungs it's beta 2 because there's two lungs. So beta has to do with adrenergic receptors. And there's alpha adrenergic receptors as well. Yeah. Overlap. There could be some overlap, of course. The higher brain can coordinate both systems. And I'm not talking about the cerebral cortex. I'm talking about, the hypothalamus and the brainstem, medulla oblongata, right? So cranial nerves, you've learned them. You know those. You're going to know them well. You'll have a little bit. I'll ask a couple questions on the exam, but some on the lab. So these have both somatic and autonomic. But know this, the cranial nerves, remember those 12 cranial nerves? They're really all parasympathetic. Think about it. They're all parasympathetic. Like the vagus nerve is my favorite, right? Everybody knows the vagus nerve is cranial nerve 10. And it's a vagus nerve because it's vagus because it's a vagrant. It goes all the way from the brain all the way down to the pelvis even. So cranial nerve 10 is very parasympathetic, mostly rest and digest. So it's big in the digestive system and the heart and the lungs as well, especially the heart, but it's all about parasympathetic. So the 12 cranial nerves, some of them are autonomic. Actually, 4 of them are directly autonomic, but this by far is the most autonomic. Yeah. Don't worry about the exceptions there. Now, here's a picture, not as good as mine, but this is where you should live. Again, Jeremiah, I would get a tattoo of this if you have the money and the time this week, just so you never forget this. So in the somatic nervous system, I'm not going to say SNS because that's horseshit, right? Because that'll screw us up. So this is the somatic nervous system. So in the central nervous system, like coming out of your spinal cord, after I thought about moving a muscle, that's just one lower motor neuron that goes to a muscle, skeletal muscle, and releases acetylcholine with cholinergic receptors. And they happen to be muscarinic receptors on the skeletal muscle. And they're always excitatory to contract. If we want to inhibit a muscle, like remember reciprocal inhibition, then we're going to release a different neurotransmitter like glycine or something like that from the neuron. But right here, we're stimulating. Now that's simple, straightforward, voluntary muscle contraction, somatic nervous system. But in the autonomic nervous system, you got this whole business about preganglionic neuron in the CNS with the nuclei, and then you have the ganglion. So let's start with parasympathetic first. Parasympathetic have very long preganglionic neurons. So the ganglion is closer to the effector. And that preganglionic neuron is always releasing acetylcholine. Therefore, the postganglionic neuron has cholinergic receptors. In this case, they're usually nicotinic. Now, the postganglionic neurons in the parasympathetic nervous system are usually short, closer to the effector, right? So they always release acetylcholine. Always. And it depends. Is it positive or negative? Depends where. Like acetylcholine, parasympathetic to the heart, is inhibitory. It slows down the heart rate. But to the digestive system, it's stimulatory or excitatory to help digest that burrito. Now, there's 2 pathways for sympathetic, and they're very simple when you look at them. Sympathetic have a relatively short preganglionic neurons, but guess what? And this is what you got to remember. They all, in sympathetic and parasympathetic, all preganglionic neurons release acetylcholine. Therefore, all postganglionic cell bodies contain cholinergic receptors. And in this case, this one's nicotinic. And then the postganglionic neuron in the sympathetic nervous system is usually longer than para, and it releases norepinephrine. So the receptors, even here in the digestive system, are adrenergic. And on the heart, of course, they're adrenergic. So norepinephrine is going to be inhibitory to the digestive system, but excitatory towards the heart. So these are adrenergic receptors because the postganglionic neurons in the sympathetic nervous system are releasing norepinephrine. Now this pathway goes to the adrenal medulla, and that's the adrenal gland. So the preganglionic neurons, also sympathetic now, this is still sympathetic, they release acetylcholine to the adrenal medulla. Why is the adrenal medulla so important? The cortex of the medulla, and now you should know by now that the cortex is the outer part, also known as the bark. Cortex means bark. But the nervous system controls the adrenal medulla because the adrenal medulla is about the nervous system. And what does the adrenal medulla do? It has chromaffin cells that produce and release epinephrine into the blood. But that's a hormone now. So this preganglionic neuron always releases acetylcholine everywhere, parasympathetic and sympathetic. In this particular pathway, the acetylcholine will be released to the cells of the adrenal medulla, and then the adrenal medulla will release epinephrine as a hormone, also known as adrenaline, into the blood. Like again, if you're sitting there on campus when you're eating your burrito at 9:30 at night, 10 o'clock after lab, and you're digesting nicely, And then all of a sudden, a coyote comes out, right? And you get scared. Now, norepinephrine is going to be released to your digestive system to slow down your digestion of the burrito, but increase your heart rate. Sympathetic, right? You went into sympathetic. You were in parasympathetic, but now sympathetic. And then somebody takes care of the Humane Society comes and they take care of the game, a fishing game, whatever. Take the coyote away, and now you're back to your burrito. But you notice your heart's still beating. And the reason your heart's still beating maybe 20 to 30 minutes after is because hormones are slower. They move slower. They last longer. Where neurotransmitters, boom, lightning fast. Because you got to react, fight or flight, right? Am I going to fight a coyote, or am I going to run away? So the answer is clear. I want to hide under the bench and wait for Valerie to come out and save my ass. Okay? So again, this is the takeaway here. There are a couple differences, and of course, the sympathetic preganglionic neurons are shorter than the parasympathetic. All preganglionic neurons, parasympathetic and sympathetic, release acetylcholine. Therefore, all the receptors on the cell bodies of the, or dendrites of the postganglionic neurons are cholinergic. Whew. Okay. Now, if you don't know this by now, we gotta really talk. So parasympathetic is more maintenance function, slowing down, rest, repose, digest. Lowers the amount of energy demand on your body with the blood flow, oxygen, so forth, so on, hormones. Sympathetic is a mobilization. Let's get going. Let's go. Boots to the floor. Let's move, right? Sometimes there's dual innervation, but this doesn't happen a lot. This really doesn't happen. These are antagonistic. These are pretty much evil cousins to each other. Maybe there's one place where I could show you that it makes sense when they work together. So it's antagonistic, but it maintains homeostasis somehow, some way, and it works. And evolution really shows that. So parasympathetic division, low energy use, maintenance, digestion, urination. That's what diuresis means, to avoid. Mostly waste in some order, defecation through the waste and food. So again, parasympathetic is going to control these things. And sympathetic is going to be kind of the opposite. Sympathetic will stop digestion, retain more water, stop the defecation reflex. So there it is, rest and digest, rest and repose. So relaxing, reading after a meal or during class, falling asleep, right? So everything's low, blood pressure is low, heart rate is low, and respiration rate, breaths per minute are decreased. And then your gastrointestinal activity is high. Digestion is high when you're in sympathetic. And remember this, your pupils are constricted, especially in the presence of light, whereas sympathetic is going to dilate your pupils. Remember, the pupils are just the space between the choroid irises, right, which you saw in the cow eye. And the lenses, your lenses, remember that squeaky thing you pulled out of the eye? Look kind of like a soft, actually they're pretty soft, marbly stuff. So it's more about close vision. Where sympathetic, your lens is going to change shape, actually, become a little more convex to key in on distant vision or far away vision. So that leads us to the other evil cousin, the sympathetics. It's basically the opposite, fight or flight. And you have to decide. So the blood has to get to the brain quickly. So when you exercise, you're basically always in sympathetic stimulation, if there's a better way to do it, right? And how does it happen? Through exercise, of course. Excitement, emergency. See somebody drowning, or a professor getting attacked by a coyote. And then you have embarrassment. I don't get that one, but it happens. None of us really get embarrassed, do we? And that activates the sympathetic, which is increased heart rate. Lack of salivary secretion, especially mucus, that stops. Cold, because blood flow goes to other areas that are more essential, like your skeletal muscle, like your brain, sometimes your heart. So you get a little bit colder because your body temperature will drop based on that. Just that's that first reaction. Sweaty skin, but it's a different sweat, a nervous sweat. And your pupils dilate means that your irises will contract outward. Remember the oculomotor nerve, which is really more about constriction, parasympathetic. Oculomotor nerve is cranial nerve 3, which happens to be autonomic and motor at the same time, mostly for constriction of the pupil. So here's what happens. Physical activity. Let's get to normal stuff. Forget about the coyote and all that shit. Now we're talking about just vigorous physical activity, which is what we should be doing. So where's the blood need to be shunted? It needs to be shunted to your muscles that are doing all the work, and the heart to keep your cardiac output going so you get oxygen to those muscles. Really, that's basically what it's all about. So the sympathetic division is not an emergency like they're making this out to be. It's used during exercise. It's used completely appropriately. Like when you're taking a test and you're nervous, sympathetic makes you actually key in more on what you're doing because you're getting more blood flow to the brain. Now here's a catch. Be careful here because technically sympathetic nervous system constricts your blood vessels to increase your blood pressure, but it dilates your bronchioles. Bronchioles are your airways, pretty much going into each lobe of your lungs, left and right. Or bronchioles are actually deeper. The bronchi are the big tubes, conducting air tubes. Bronchioles are closer down to the bottoms, the deep part of the lungs. So these have muscular linings, of course, smooth muscles. So these are dilated. So epinephrine, and they're going to be beta 2 adrenergic receptors on the muscles of the bronchioles will dilate. Dilate, not constrict. So they'll inhibit contraction. And the liver, of course, has to break down glycogen. And that's called glyco. I don't know why I'm telling you people this. Glyco, you're not going to learn this till next semester. Genolysis. But I bet you guys are smart enough now. Not even smart enough. Nobody's smarter than anybody here. Just that I've been walking around the planet for longer. Been to more Chick-fil-A's than you. So glycogenolysis, think of what that means. You could figure this out. Like glycogen, what the hell is that? That's the stuff in the liver that's basically the storage form of glucose. And it's in the skeletal muscles too. Lysis means to break it up. So the glycogen will break down to glucose in the presence of epinephrine in the sympathetic, because you need glucose in your blood to get to your muscles, because you need glucose to get into your cells to make ATP ultimately in the presence of oxygen. I don't make this stuff up. So key anatomical differences. Now we're going to talk about short and long pre and post ganglionic fibers and the receptors. So this is pretty easy to remember. Parasympathetic is cranio and sacral. I bet you know what that means. Cranium is around the brainstem, right? Where the cranial nerves are. Sacral is down below the lumbar spine, towards the bottom. Caudal. You remember these words. We're getting somewhere in this class. So these parasympathetic preganglionic neurons basically started in the brainstem or outside of the brainstem, like from cranial nerves, and down into the sacrum. So nothing in between. Whereas the sympathetic fibers, they're around the thoracic mostly, and they're called paravertebral neurons. And a picture's coming up, so that'll help you understand. So usually they go like from the first thoracic down to about the second or third lumbar. Yeah. So again, this is put in words. Sometimes the picture helps. So parasympathetic have long preganglionic neurons and short postganglionic. So the ganglia are closer to the effectors, which is cardiac muscle, smooth muscle, and glands. Sympathetic have short preganglionic and long postganglionic neurons. So the ganglion is closer to the spinal cord, really, closer to the spine. So you should know that difference, the anatomical difference. Location of the ganglia, remember ganglia are the cell bodies and the axon terminals in the PNS. So in parasympathetic, they're closer to the effector, like I said. Now, what are the effector? Why not talk about it again? The effector is cardiac muscle, like the heart, smooth muscle, like the blood vessels and organs, and the glands. Sympathetic ganglia are close to the spinal cord, like I said. So we really need a picture here. And here's a picture, kind of. So this is a parasympathetic branch, and take a look at this. Pretty good. I think this is pretty good. Let's see how this Pearson book does this. This is a mid-sagittal section. Now you're looking at a lateral view, but you could see how the nuclei of the preganglionic neurons are cranial and sacral, and then they branch from there. Parasympathetic. So long preganglionic neurons, short postganglionic neurons, and the ganglia are all closer to the effector. Look at the effectors. The eye, smooth muscle, the glands, cardiac muscle, smooth muscle, the bronchioles, smooth muscle, the digestive tract, pancreas, blood supply, digestion, that's a gland. This is a gland. It secretes hormones and exocrine. Enzymes for digestion. Liver is a gland. Gallbladder is a gland. Bladder is a gland, basically. And genitals, right? Smooth muscle. So this has to do with the reproduction. Now let's look at the sympathetic. And the sympathetic has short preganglionic neurons. So the ganglia are all along the spinal cord, and long postganglionic. And the effectors are basically the same. Basically the same. Right, if you go down here. So sympathetic may have something more than the skin. It's probably why acetylcholine is released from the sympathetic postganglionic neurons. So here's a little table. I usually like these. And again, I think this is a good idea if you're preparing for the departmental final, to go through these from my PowerPoints. I know it takes a long time, but it's one of those things. Your learning outcome is going to be excellent. If you could do this, you just go through. And this is just showing what I showed you in the picture before. So you know what? I mean, it doesn't take long to look at a picture and see if you know what's going on, and then just read these names just to get the name into your head, and it's going to ring a bell, because it's the only way to really prepare for a test like this. My test is straightforward. You know, it's basically what I'm teaching and what's in the study questions. So again, parasympathetic, maybe just remember it's craniosacral division, and where the terminal ganglia are close to the effectors, which are really target organs, and effectors are the same thing. So they have short postganglionic fibers. And this breaks it down again. Just go through this. I think these questions, like, I'm glad you didn't take the test yet, because you could look at these. And I'll give you my exam tonight. I mean, but go through those study questions first. I'm going to have to make sure you get those answer keys in a couple of days. So, but don't wait for that. You know, if you have, I know you have to do the lab practical on top of all this, but you should be ready for the lab practical. And that's due anyway by Saturday night, I believe, right? So get that done. This is again talking about some parasympathetic, like the oculomotor nerve, cranial nerve 3, constricts, right? You don't have to worry, but the ciliary ganglion, the ciliary bodies, again, are part of the eye. Again, this is probably more for AP2. Remember all that, but know about these your pupillary constriction. Facial nerve. This is really good. Again, I don't need you to know the names of the ganglia, but it kind of makes sense. So the glands, like your lacrimal gland, tear gland, is innervated by facial nerve. Facial nerve is also sensory for taste on the tongue, gustation, but motor to the glands. Remember, it's one of the effectors of the autonomic parasympathetic is the lacrimal glands. Cranial nerve 9 is for the parotid gland innervation. That's, of course, parasympathetic, because saliva and salivation and tears are about parasympathetic. You might say, oh my God, well, if the coyote's chasing me, I'm going to cry. But really, crying, lacrimation, is not really designed to be emotional. It's more a protective mechanism to clear your eyes and keep your eyes clean, is really what it's for. So I'm not a neuropsychologist, although I play one on TV, but the emotional part may have something to do with the limbic system, not so much the autonomic nervous system, if you could follow what I mean. So salivary glands are innervated parasympathetically. That's why you get, when you're in sympathetic stimulation, your mouth gets dry, right? So again, this is too much. And I hope they don't ask this on the exam, the actual ganglia for each of these. You might get cranial nerve questions. I mean, the more nervous system that's on this, the better, because you've just learned it. You know, it's the chemistry part that you got to go back and all the tissue types, which really, you did pretty well. I'm pretty confident you'll do okay on this. So again, here's the most parasympathetic cranial nerve. Remember, all cranial nerves are paired, and this one happens to come off the medulla oblongata, the brain stem. So again, this makes up a lot of preganglionic fibers. Remember, these are long. This is parasympathetic, so your preganglionic neurons are long, and the ganglia is closer to the effectors. So this is a good takeaway because you have a lot of things going on in the heart, the lungs, which is pulmonary, so cardiac, pulmonary, and esophageal going into the diaphragm, which is all digestive. And look at all this: stomach, liver, gallbladder, pancreas, small intestine. And you learn those at the beginning of the semester, just where they are. In A&P2, you'll talk about digestion and respiration and endocrine. But now you just got to get a good idea of the nervous system. So this is sacral now. Sacral, you might remember, a splanchnic nerve always has to do with the sacral area, going to the reproductive organs in the lower gastrointestinal. Like hypogastric, just remember that term means below the stomach. So if you see something like that, and you should be familiar with words, like I don't know how many questions you're going to see on the 80 questions on the departmental final, but you're going to have to know the terminology. And inferior is not a big deal anymore. Like hypo means below, gastric means stomach. Plexus is a group of nerves, like the cervical plexus, the lumbar plexus, and the sacral plexus. And you should know them. There's like 1 or 2 questions on the lab practical about just, this is the brachial plexus, this is the cervical plexus, this is the lumbar plexus, so forth, so on. So again, parasympathetic, the walls of the intestines are smooth muscle. This is what they're talking about, smooth muscle. Intramural, mural means wall, right? When you do a mural on your wall. Intra means within. Like inter means between, but intra means within the wall. That's why it's called intramural. Like an interstate highway, like Route 80 goes across the country, basically. Interstates, in between states. But intra-highway, like I think Route 10, right, just stays within one state, so forth and so on. So it's about smooth muscle, which is the actual target of the parasympathetic and sympathetic, of course. So this is naming the ganglion, but again, this is parasympathetic. You can see because it's cranial and sacral. It has long preganglionic neurons. There you go. And in the study questions, it breaks down the stuff for you, like in pictures. I have like a matching that'll help you. So again, make sure before you go into that departmental final that you look at my study questions that I give you. You know, you have all the answer keys except for one, which you'll have in a day or two. Okay. So again, breaking the same thing down, just talking about the sympathetic is now, I like to call it paraspinal, but thoracolumbar is good because the parasympathetic is craniosacral, but the sympathetic is thoracolumbar. And it emanates from the lateral horns of the spinal cord. You have to know what the lateral horn is. Remember the gray matter? So the cell bodies in the spinal cord for autonomic neurons are basically start in the lateral horns of the spinal cord. And usually they're unmyelinated in sympathetic preganglionic fibers. Can't say that 100% though. Now you know right away. This is the sympathetic ganglion because it's paraspinal. It's thoracolumbar. And here's your postganglionic neurons, which I bet you all of them are releasing norepinephrine, except maybe here to the sweat glands. Really, was there sweat glands? Yeah, the only exception is to sweat glands. Sympathetic postganglionic neurons release acetylcholine. Other than that, it's all norepinephrine. Therefore, On the effectors, the receptors are adrenergic. But remember, all the receptors of the postganglionic cell bodies are all cholinergic. When I say cholinergic, that means it's for acetylcholine. There's two types of cholinergic receptors. There's nicotinic and muscarinic. Usually the ganglionic fibers, postganglionic cell bodies, are nicotinic. Just like nicotine, which is always excitatory. That's how they found that name. Because nicotine is an excitatory chemical that affects your nervous system for waking you up or exciting, increasing your heart rate and so forth. Now, this is breaking down the trunks. Again, I don't go there with this class. I don't go there with chains and ganglia specifically, but it's kind of like the plexuses where they kind of branch to different parts. So paravertebral is a better way to look at the sympathetic. It's paravertebral ganglia. And they have branches. Again, this is showing where they are in the spinal nerves. And you should know something about this. You should know what the posterior horn, the lateral horn, anterior horn, great commissure, central canal. You should know all that stuff. Posterior median sulcus and anterior median fissure. And then you have the dorsal root ganglion. That's all over the practical. Dorsal root, ventral root. So this is motor. So the ventral root carries motor efferent fibers. In this case, the green is an autonomic preganglionic neuron. So here's a sympathetic postganglionic neuron going to the effector. In this case, could be a muscle or gland, sweat gland. So this is, again, this is just autonomic, and this is sympathetic because it's paravertebral. And this is the ganglia. It's not the dorsal root ganglion. This is a sympathetic ganglion. So you can see, if you look close, you can see kind of with the way I drew it, right? Coming out. So here's the effectors, the erector pili muscle, which is a smooth muscle. Remember that from my practical 1 in the integument chapter. Smooth muscle in the blood vessels. Effectors, right? Pathways to the head. So you have your superior cervical ganglion. Now this is again sympathetic, right? Skin and blood vessels. Iris, right? Iris, dilator muscles, which are called radial muscles, inhibit salivation and nasal secretions. Smooth muscle of the upper eyelid and branch, of course, to the heart. Pathways to the thorax, cardiac plexus, thyroid gland in the skin, lungs, and esophagus. So these are all just places they're going. And the thorax, right? Again, you don't know a lot of these things. It's just showing you all the different places, the effectors. Sympathetic versus parasympathetic. So what is this one? This is sympathetic, right? Paravertebral. Same effectors, just a different neurotransmitter being released. That's the whole thing. So these are the splanchnic outside of the trunk. Splanchnic nerves, of course, down low in the pelvis. Lumbar and sacral. Splanchnic nerves are, again, this is autonomic, sympathetic in this. So you have your abdominal organs and you have reproductive organs too, down in the lower pelvis. Celiac ganglion. Here's celiac. That always has to do with the intestines, just to get used to these words. Celiac, and you'll learn the arteries and veins in A&P2. So just to know this, we might see that in the pig, celiac artery, and you'll see the pig. You'll see all the different organs. First you'll see the heart. You'll see all the intestines and diaphragm. Reproductive organs are kind of hard in the fetal pig, but you could see the lungs, the kidney, the spleen, and again, blood vessels too. So you get a good look at the pig, which is a lot better when you see it in person than if you see it on a video, because next semester you pretty much spend the whole time dissecting the pig in every lab almost, whether you take it online or in class. So you'll be doing it at home. They'll send you a pig, right? So look at all those, and you can see some of the nerves, but mostly the blood vessels are easier to see. Nerves are hard to see. So again, I'm not going to go through this every pathway. Again, it all comes down to the same thing. You know, paravertebrus is still sympathetic. Okay, now this is important. Synapses with the adrenal medulla. So remember, the cortex of the adrenal gland is about endocrine. It's about all the hormones that are released from the adrenal cortex. But there's only one hormone released from the adrenal medulla, and that's epinephrine, because it's made there as a hormone. So again, it's considered a misplaced sympathetic ganglion, because the adrenal medulla is derived from the same tissue as the nervous system, and the adrenal cortex is opposite. One second. Give me 1 second, sorry. Okay, so the adrenal medulla, very neuroendocrine related, especially nervous system. And here it is. So this is only sympathetic. This is not parasympathetic. So the preganglionic neurons will synapse in the adrenal medulla with these cells, chromaffin cells, that produce epinephrine and release it into the blood. I don't know why it's a blue blood vessel, but it might be a portal. So let me tell you this. This is really important. The neurotransmitter that's released from these sympathetic preganglionic neurons is acetylcholine. Therefore, in the adrenal medulla, these cells have cholinergic receptors, and they are nicotinic and muscarinic, which you'll see. Visceral reflexes, again, we did somatic reflexes, which, again, is all the pathways we learned about the spinal cord. And for the exams, you should know the difference between the stretch reflex, the tendon reflex, and the cross extensor reflex. Pretty simply, and I gave you study questions where you can go through them. So please, definitely before you, of course you're going to do that before you do my exam, but do the reflexes before you do, or do the questions on the reflex before you do the departmental final. So now visceral sensory neurons. So now we have the afferent coming into the CNS that are picking up visceral changes, like chemical changes, like oxygen, hydrogen, which is acid. Remember, H plus is acid, right? H plus is acid, and bicarbonate ion is a buffer, CO3 minus again, and OH, hydroxide ion, is a base, and with a pH and all that. Stretch of the, like, especially the digestive tubes, you know, your stomach, your small intestine, your large intestine. Changes in temperature. Now, these are all autonomic. These are not somatic senses. You can think about this, right? This is not talking about, you know, light touch, vibration, pain. I mean, there's pain receptors too, but still, it's really incoming. It's not somatic. It's visceral. So a lot of free nerve endings, not so much encapsulated. And everything still comes in, sensory always comes in through the dorsal root, and the ganglia is the dorsal root ganglion. So now we're talking about sensory now. Everything we talked about today, up until right now, was motor, efferent, but now we're talking about afferent. So the vagus nerve has some afferent qualities as well, bringing things in. So again, sensory, you have your second order sensory neurons. First order are the ones that come from the receptor. Second order are now going into the brain. Third order usually goes to the cerebral cortex from the thalamus most of the time. Because remember, the thalamus is part of the brain, or the diencephalon, that relays all sensory input except for smell. So this is a visceral reflex arc now, an autonomic reflex. So again, it still has a receptor, just like somatic, a sensory neuron that comes in the dorsal root ganglion, or dorsal root, and has a ganglion in the dorsal root. Integration center, which is usually in the lateral horn of the gray matter, and the output is the motor part, which you already know, the effectors. So the reflex arc of visceral reflex arc has two consecutive neurons in the motor pathway, right? Afferent fibers are visceral sensory neurons, of course. And let me say it again. The effectors are smooth muscle, cardiac muscle, and glands. Whereas somatic reflex, the output is the skeletal muscle, like the knee-jerk reflex. The agonistic or the agonist muscle is the quadriceps group. But now we're going back to the gland, like the heart, the blood vessels, the digestive tubes are glands. Now this is defecation and emptying your bladder through urination, and their reflexes. Now this is a term, I don't know if I used it since the beginning of the nervous system, but the enteric nervous system is basically part of the autonomic nervous system, but only involves the bladder and the digestive system, really. So enteric means the organs of the pelvis or the abdomen. And of course, this isn't involuntary. So enteric is just the autonomic nervous system as in regards to those parts, like your digestive system especially. Sometimes they say that your gut has its own brain. Well, I think this is what they mean biologically. So you have to have sensory neurons because you have to have the reflexes. Interneurons are always integrating. And of course, sensory is afferent, interneuron, and that always comes in dorsally into the spinal cord. Interneurons usually always within the CNS, in the spinal cord, integrating, associating. And the motor neurons are efferent, going out to the effector, out of the CNS, that is. And that comes out ventrally. Remember, dorsal is sensory, afferent into the spinal cord, and motor is efferent, ventral, out of the spinal cord. So it's the same thing for your visceral reflex, just like it was for the somatic reflexes. So a receptor in the viscera, say your bladder, right? And that responds to a full bladder, like it responds to stretch, right? When we have, a couple of waters and then the strawberry milkshake that Valerie's going to buy from me at Chick-fil-A. So that receptor is part of a visceral sensory neuron, which always comes in the back, right? Dorsal root. And the cell body of that unipolar neuron, says most sensory neurons are pseudo-unipolar or unipolar, is in the dorsal root ganglion, because the dorsal root ganglion is a group of cell bodies in the PNS, in this case, dorsal, because it's sensory. Happens to be autonomic, and this is drawn in green or blue in this case. I don't know, sometimes it's green. Now there's no interneuron here, but there's an integration center. So this only involves one synapse. So it's monosynaptic, this particular one. Right, so the integration center may be preganglionic and maybe in the dorsal root, but a lot of times it's in the lateral horn of the gray matter, the integration center. Just like the somatic reflex, same number of parts. And then you have the efferent motor neuron out to the effector. And in the case of the bladder, full bladder, the effector is going to be the smooth muscle that makes up the internal sphincter of your urethra, or of your bladder, really, to allow for urination, or micturition reflex, it's called. But you have an external urethra, or external sphincter that you can control voluntarily because it's skeletal muscle. So even though your internal sphincter is ready to open up and urinate, your voluntary skeletal muscle sphincter that you control is intact and holds in your bladder. So at least you can get all the way onto Route 202 and get home before your milkshake is ready to go. And that works for defecation as well. Same thing with the sphincters, internal and external. One is smooth muscle, which is involuntary. The other one is skeletal muscle, and it's usually external, is voluntary control. So this is what I've been talking about, these neurotransmitters. And the two are the ones you know the best. Acetylcholine, which is relatively large, and that amine, norepinephrine. You could say epinephrine, it's the same thing, please, at this point. So acetylcholine, and it's the same neurotransmitter that we used in muscle contraction, the skeletal muscle, somatic nervous system. And the fibers that release it are cholinergic, and the receptors that accept it is cholinergic. So whenever you hear cholinergic, right, Paul, you have to write this down. Cholinergic is always ACH. Cholinergic. So cholinergic is ACH. But now norepinephrine is released by adrenergic fibers. So the receptors in the neurons are adrenergic because it's adrenaline. Norepinephrine is the same as noradrenaline. Epinephrine is the same as adrenaline. So all four of them are basically the same thing. Adrenaline is epinephrine. Okay? So adrenergic makes sense to be the receptor and the fiber that's releasing it, a neuron. When they say fiber, they're talking about axon terminals. Let's face it. All right? So almost all sympathetic post-ganglionic, now to the effector, release norepinephrine, except where I told you this. In the sympathetic, the postganglionic neurons release acetylcholine to sweat glands. I don't know why. That's evolution over time. But most of the time, the postganglionic neurons are releasing norepinephrine to the effectors as a neurotransmitter. So now, the effects of the neurotransmitter depends on the receptor. That's how we found out about these neurotransmitters. If they're cholinergic, it has to be what, Paul? ACH. And if it's adrenergic, what does this have to be, Gabriella? It's got to be norepinephrine. She never has her mic on. And remember this picture? Again, this is probably one of those screensavers or a Jeremiah Campbell tattoo. Well, you should remember how this works and the difference between the pre and post ganglionic fibers and the sympathetic versus parasympathetic. And this is all ANS because the whole chapter is about the ANS, autonomic nervous system. So if it's stimulatory, which is positive, inhibitory, which is negative, has to do with the organ, right? Remember the professor eating the burrito at 10 o'clock on campus when the coyote comes. What's going to be excitatory? What's going to be inhibitory? What's sympathetic? What's parasympathetic? So to confuse you even more, and I know Torner's listening right now. She's on her game these days. Cholinergic only means what? ACH. So that these two are two different types of cholinergic receptors. Nicotinic, which is always excitatory because nicotine is excitatory, right? When you're vaping down Route 10 on your way to get that milkshake and waffle fries, you're vaping and the nicotine makes you wake up. Same thing with muscarinic. So they found this, of course, in mice, and muscarine is a chemical released in mice, actually, that excites most of the time the postsynaptic or the effector. So basically, and this is mushroom poison, muscarine. It's a mushroom poison that we use, but mice release it as well. So we found that mimics the effect of those receptors, or the outcome of those receptors. But remember, these two are cholinergic. It's all about acetylcholine. So usually the first synapse is nicotinic, and the second one is muscarinic. Let me say that again. Usually the first synapse, autonomic, in the ganglion is nicotinic, and the second one to the effector is muscarinic, usually. Sometimes it's both. So where are nicotinic receptors? Remember, these are cholinergic. It's acetylcholine, no adrenaline here. So all postsynaptic neurons have nicotinic receptors, whether it's sympathetic or parasympathetic. And also in the adrenal medulla, the hormone-producing cells are called chromaffin. Sorry, it's got an H, I think. Two Fs, chromaffin cells. Those are the hormone producing. And the hormone is what? It's epinephrine. That's it. There's no other hormone released there. But the neurotransmitter to those cells is acetylcholine, and it's a nicotinic receptor. Crazy, right? So go back to the picture if you need. So right here, these are nicotinic receptors on those chromaffin cells. And that's cholinergic, that's acetylcholine, every cell. Okay, Sarcolemma is, now I don't know why this is brought up here, but sarcolemma is the muscle, right? The muscle membrane. So of course that's nicotinic. That's nicotinic as well. That might be a question you might want to know. The sarcolemma, the muscle membrane, has cholinergic, of course, because you know acetylcholine is the main neurotransmitter released during skeletal muscle contraction, somatic muscle contraction, voluntary muscle contraction. So that's nicotinic, though. This is what you have to remember. Good luck. It's not easy, I know. But who knows? Maybe you'll remember that just one time. So acetylcholine is always on nicotinic receptors, always stimulatory. So that makes sense, right? So the ion channels open. What? Where'd that come from? Yeah, ion channels, that's depolarization. Sodium coming in, causing an action potential. That's what excitation is. Action potential after enough depolarization to reach threshold at minus 55 millivolts. Remember, the neuron resting membrane potential, minus 70 millivolts. After depolarization, sodium influx, if it reaches minus 55, after many graded potentials, you'll have an action potential that peaks out at about plus 30 millivolts. And then repolarizes, which means potassium is leaving the cell. Sodium channels are closed, and the cell will repolarize back to the resting membrane potential at minus 70 millivolts or hyperpolarize. Hyperpolarization is below minus 70 millivolts, like minus 190, not 190, minus 90 millivolts. And it's really hard to get an action potential. So sometimes the cell is in refractory period, which is no way, no how you're going to get another action potential. So muscarinic. Now, where are the muscarinics? We know about nicotinic. So muscarinic, and remember, these are cholinergic, which is acetylcholine, right? So these are on all effector cells that release or that have acetylcholine in their synapses. So all the effector cells, so like the SA node of the heart, the blood, not so much the blood vessels, but in glands, right? So these are more about the effectors. So like I said, the nicotinic are usually the first. And remember, this muscarinic is also acetylcholine. Depending on the effector, it can be excitatory or inhibitory. So inhibitory would be minus, excitatory plus. Right? And so it depends on the receptor type and where. Like on the heart, right? Acetylcholine is inhibitory, right? It's inhibitory, slows the heart rate down. So the muscarinic receptors are on the heart. And what are the muscarinic receptors for? Acetylcholine, because they're cholinergic. So you have to kind of memorize cholinergic receptors. There's two types, nicotinic and muscarinic. Cholinergic, of course, is for acetylcholine only. Yeah. So in the intestinal smooth muscle, which lines the walls, inside the walls of the digestive tubes from your esophagus all the way to your rectum, acetylcholine is excitatory because it wants to contract those muscles to move and digest the food, which you'll learn in A&P2. So now adrenergic receptors. Adrenergic receptors. And there's two types that you need to know. There's alpha and there's beta. I might have mentioned beta. So they're divided, alpha is divided into alpha 1 and alpha 2. And beta is divided into beta 1, beta 2, and beta 3. So beta 1 you're going to see is the heart. Because remember, there's one heart for epinephrine receptors. Beta 2 is more lungs and other places because there's two lungs. Beta 3 is mostly the liver, again, for glycogenolysis. Because epinephrine release, sympathetic, breaks down glucose, or breaks down glycogen, into glucose. Increases blood glucose so you're ready to run away and make ATP. So we'll learn about those. Adrenergic receptors, of course, is about norepinephrine. That's number one. So beta 1 receptors increase things, of course. Beta 2 is bronchial relaxation. Remember, bronchial dilation, not constriction. But blood vessel constriction, but blood vessels don't use beta 1, they use alpha. Blood vessels use alpha, not beta. The heart uses beta 1, see, cardiac muscle, sorry, I missed that. And that's to increase the rate of action potentials at the SA node, the sinoatrial node, increasing heart rate. Makes sense. Oh, this is nice. This is nice. I love these things. So right away, acetylcholine and norepinephrine, these are cholinergic. So let's see what's important with your adrenergic receptors. You have beta-1 is heart predominantly. Remember, there's one heart, beta-1. Beta-2 is for the lungs. Lungs, you have 2 lungs, right? That's going in the Whitney, that picture, right? Beta-3 is adipose tissue and some parts of the liver too. So beta-2 is basically for the glycogenolysis. So beta-3, you just got to remember adipose tissue. That's easy. I like this. Now, alpha-1 are blood vessels. And there aren't a lot of cholinergic receptors on blood vessels. It's mostly sympathetic constriction. So alpha-1 receptors, when bound to norepinephrine, they're going to constrict blood vessels and then increase your blood pressure. But in salivary glands, they're going to do the opposite. They're going to inhibit. So alpha-1 bound with norepinephrine and the blood vessels is stimulatory or excitatory, where the salivary glands is inhibitory. Alpha-2 we don't talk about much, so that's more about the pancreas and, of course, release of insulin or glucagon. Glucagon is kind of the opposite, evil cousin of insulin, where insulin will decrease your blood glucose levels by bringing glucose into the cells, where glucagon does the opposite. It increases your blood glucose levels when you need it for, and so glucagon technically is more sympathetic. Insulin is more parasympathetic. That makes a lot of sense, but I won't ask you that. The departmental final may allude to that, but that's really AMP2, which is endocrine, about hormones. So here are some receptors, and this is giving you some examples of some chemicals that elicit responses in different parts of the body based on the autonomic nervous system. So nicotinic agents are always stimulatory. So that's all sympathetic, increases your blood pressure, right? So nicotine, again, when are you going to use nicotine? Probably to help somebody stop smoking, like a nicotine patch or nicotine lozengers, whatever they're called, and the spray that you put in your mouth just to help you stop smoking. Muscarinic or muscarine, you don't have to remember this. So again, this is parasympathetic, slows down, lowers pressure. So they give this to people with glaucoma, usually in the form of eye drops. Now, acetylcholinesterase inhibitors, these are kind of important. You should take this with you, this knowledge. Now remember, acetylcholinesterase is the enzyme that destroys acetylcholine. So this will decrease the acetylcholine and decrease muscle contraction. Yeah, so acetylcholinesterase, if you stop acetylcholinesterase, you're going to get more muscle contractions because you're stopping the enzyme that destroys acetylcholine. So a condition like MG, myasthenia gravis, which is an autoimmune condition where the receptors for acetylcholine are destroyed, you want to increase the acetylcholine, so hopefully you get more muscle contraction. So basically causes contraction, right? Causes contraction. So neostigmine is a drug that's used for MG. Sarin kind of paralyzes insects, uses an insecticide to paralyze them spastically. Right? Then you have adrenergic agents, sympathetic, minometric, like albuterol, which causes a bronchial dilation for somebody who has asthma. Right? You may have heard of it, you may have used it, albuterol in those puffer sprays. Phenylephrine, of course, is an agonist for norepinephrine. Sometimes they're used to clear up nasal decongestions. You have to show your ID at your age when you buy this stuff from a drugstore, right? Because it can make you a little dizzy and you can't really drive. And if you mix it with alcohol, bye-bye, good night. See you, Anthony's. See you next year. Right? And the sympatholytic agents, now this is different. This will decrease your sympathetic nervous system. So remember, the receptors for adrenaline or norepinephrine are beta receptors. So you might have heard of medications called beta blockers. So these are given, like if you go in grandma's medicine cabinet, you're probably going to see something called atenolol or propanolol. And these are beta blockers that they give to grandma and grandpa to decrease their blood pressure and decrease the demand on their heart for oxygen, so they don't, stress the heart out. So it slows everything down. So they're blocking norepinephrine binding to the heart, right? Blocking, so it overall decreases your blood pressure, even though they're just beta blockers, not alpha blockers. But again, they're blocking norepinephrine. So beta blockers are used to slow the heart rate down and ultimately will decrease your blood pressure, decrease the demand. And hypertension is high blood pressure, which is a risk for cardiovascular disease or stroke. So many people do that. That's a good drug to take. I'm not saying everybody should take it, but it's a drug that you could take for a long time without too many side effects. Because the sympathetic nervous system can be overactive. You can just get that from exercising, right? Using your sympathetic nervous system. So dual innervation is still antagonistic. They really work against each other, but they do want to control homeostasis. So sympathetic and parasympathetic tone. So sympathetic is more about tone, nervous tone, not muscle tone, to make sure your blood vessels are ready to pump. If you get up too fast, you don't fall down, right? Did you ever put your head down between your knees for a long time, tying your shoes or painting your toenails, which I don't do, but I'll try it this summer. So I have nothing to do on Wednesday nights from now on, so I might as well paint my toenails. So if you bend down for a long time and then get up real quick, your sympathetic nervous system has to control the flow of blood to your brain so you don't fall on your ass. And that dizziness is called syncope. Syncope is like a dizziness where you feel like you're going to fall, kind of black out because your brain didn't get blood fast enough. And you'll learn about that in cardiovascular, but that's what sympathetic and parasympathetic tone works. Now, if there's too much vagal, now remember, vagus nerve is parasympathetic. A vagal response is decreasing blood pressure and heart rate. So sometimes it's too much vagal tone. If that's hyperactive, then your blood pressure may drop too low. So they have to change your vagus production. Vasovagal maneuvers. Again, you'll learn that in AMP2. Now, do we really have to go over this again? Sympathetic division increases? Yeah, you know that. Inhibits. This is everything, right? And I think you could have told me this, right? I kind of mentioned this before. There's really no parasympathetic innervation to blood vessels. It's all alpha adrenergic. It's all norepinephrine. It's all sympathetic. So that causes constriction of blood vessels, which increases your blood pressure, or it can divert blood to where you need it, like more essential areas, like your heart or your brain or your skeletal muscles, in case you're eating a burrito and you want to run away from a coyote or fight the coyote or just cry. But then you wouldn't be able to cry because it's parasympathetic. So again, sympathetic tone is mostly about the blood vessels and keeping your blood vessels constricted enough to keep your blood pressure homeostatic where it doesn't drop. Because you're going to learn between what you learned in neuro and endocrine next semester that your mechanisms of your body are much more about raising blood pressure. Your body's more concerned about your blood pressure dropping than it is going up. That's probably why there's so much beta blockers in grandma's cabinet, because more people have high blood pressure. So I don't think evolution caught up right now to blood pressure. I think we're still worried about losing blood. Remember back 150,000 years ago when I was worried about being lunch for the lion, right? That was my biggest concern, because if he got to me, first of all, I'd be his burrito or her burrito and I'd bleed out. So that must have happened so often that your body's so concerned about elevating your blood pressure so you don't lose blood. Same thing with blood clotting. So I don't think evolution caught up to those two things like blood clotting and hypertension. So we have much more sympathetic output when it comes to that kind of blood pressure and heart rate than we do parasympathetic, which again creates things like heart disease, hypertension, and maybe even diabetes. So parasympathetic tone is more vagal about slowing the heart rate down. You know that. Urinary tracts and reproductive as well. And that's the vagus nerve is the big producer of output from the parasympathetic nervous system. So during times of stress, of course, the sympathetic has to win. It has to win because you really have to fight or flight, right? So again, you can take drugs that block the parasympathetic response, right? It depends, and there's always if you take a drug for one thing, because of all this antagonistic business that's going on, there's going to be a side effect somewhere. So every medication, especially if you're dealing with the nervous system, is going to have a side effect somewhere else. There's no perfect. Even beta blockers are going to have side effects. Digoxin, which decreases your, well, it doesn't decrease, it increases your heart contractions to get a better cardiac output, but it has side effects, right? So cooperative effects, this doesn't happen a lot. So this one place it happens is in the reproductive system. And again, having intercourse, the only reason that anybody would want to have intercourse is to get your DNA from one generation to the next. So in order to do that, you need sexual arousal or erection. So erection, whether it's a penis or clitoris, is about inflow of blood, and that's parasympathetic. So that part, the getting blood, erection, is getting blood to the erectile tissue of the penis, which I think you do in A&P too, is about parasympathetic, vasodilation, right? Parasympathetic, the arousal part. But the ejaculation, and the whole main reason for this is to help the semen get the sperm to the fallopian tube to fuse those two nuclei. So the sympathetic part, the ejaculation, is sympathetic. So they kind of work together in this particular activity, which I heard happens on a Friday night only. I don't know if that's true, probably right after Chick-fil-A is closed. So again, the reflex, the contraction, ejaculation in the male is all about sympathetic, but the arousal is parasympathetic. And there's a chemical released, we might have mentioned it when we did neurotransmitters, called nitric oxide, not nitrous oxide, which is N2O. The nitric oxide is a pretty good vasodilator. In fact, you give it to people when they have ischemia or angina, which is chest pain due to ischemia in the heart. So originally they thought they used nitric oxide to lower blood pressure, but there was a side effect. The subjects in the clinical trials had gotten erections, so they developed a drug called Viagra, which is based on the release of nitric oxide for vasodilation to the penis. So now they use it as a treatment for erectile dysfunction. So this is one of the main areas where there's a cooperative effect and not so much the Shakespearean tragedy of antagonistic and agonist. So other roles of unique roles of the sympathetic division. Of course, the adrenal medulla. Sweat glands are very unique to the sympathetic and evolution with the acetylcholine. The erector pili muscle, I'm not sure what that's about. The only thing I can tell you there is it helps the hair follicle release sebum. Like this gives you goose flesh, right? When they're stimulated and contract. But we don't have feathers, so I don't see the reason for, showing off my feathers when I don't have them in sympathetic stimulation. Kidneys, I would say, again, you're going to learn about the kidneys in AP2, is probably more sympathetic and about increasing your blood pressure by holding on to more water and sodium with hormones like ADH. Remember ADH from the posterior pituitary, which is attached to the hypothalamus. So the hypothalamus makes ADH, antidiuretic hormone. Temperature responds to heat. Again, we talked about dilation of, not dilation, but when you're cold or when your body temperature rises, exercising, you have to dilate the skin blood vessels to get rid of the sweat to decrease your heat. But technically, when you're in sympathetic, the blood doesn't go to the skin, it just goes to the glands and the blood vessels. Because again, during sympathetic stimulation, you want to get blood diverted to the more essential organs like your brain and your glands, of course, and your heart and your blood vessels. So when it gets cold, the blood vessels constrict to stop sweating, basically. So remember, glands are also a part of the effectors. Renin from the kidneys. Renin is a chemical released from the kidneys. It's basically an enzymatic hormone that causes a cascade of events that really ultimately stops the kidneys. It comes back to it causes hormones that eventually come back to the kidneys and stop the release of sodium. So water is like, you know, like an owner of a dog. Like this, wherever sodium goes, the sodium is the dog, will pull the owner. So water follows sodium. So if sodium goes back into the kidneys and back into the blood, that's going to increase your blood pressure because the volume of blood will increase because the water will go into the blood and increase your blood volume. Yeah. Sympathetic, of course, increases your BMR, increases your metabolic rates. All right. In fact, the release of thyroid hormone works through the sympathetic nervous system because it makes more receptors for epinephrine. So basically, when thyroid hormone binds to a receptor, it makes more receptors for epinephrine. So that's why it increases your metabolism, things like thyroid hormone. And then, of course, raising blood glucose by breaking down glycogen, because you need blood glucose to, again, get to your cells to make ATP. And it also causes lipolysis, breaks down the fat cells, so the fatty acids can get into the blood because they can be used to make ATP as well. Again, that's a stored fat in adipose. Right? Again, evolution here, because again, back in the day, 150,000 years ago, when I was running away from that lion or dinosaur, maybe even, I mean, that was a couple of billion. I'm not that old. So we probably couldn't get enough glucose because there wasn't enough agriculture. It depends what you were doing, whether you were a hunter-gatherer walking around getting fruit or you were just in one village that had no agriculture. So if you didn't have glucose, you'd have to use fats for energy, and you'd be on the ketone diet all the time, right? You're just using fats, no glucose. Now we've evolved, so we can't live on the ketone diet all the time. We need to use glucose, especially in our brain. Or else our liver is going to have to convert the fatty acids to glucose. So those are the kind of questions you might get on the departmental final. Okay, localized versus diffuse. Diffuse is more around the rest of the body. So parasympathetic is short-lived, highly localized, short-lived. And sympathetic is a little bit longer, especially because the epinephrine releases a hormone. Remember, the hormone from the adrenal medulla, epinephrine, is released into the blood, and it has prolonged effects. That's why my heart keeps racing even 20 minutes after the coyote is gone. That's why when I'm eating my burrito again. And look at this, more tables. And I mean, again, what the iris is a muscle, right? The ciliary muscle has to do with the lens, right? The ciliary muscles. I think that was an answer on it. Practical. The ciliary muscle is part of the choroid, which has the suspensory ligaments that are held to the lens. And the glands, of course, salivary, sweat, adrenal medulla is basically a gland, right? So look at the ones that have no parasympathetic. These are all sympathetic, except for this one, sorry. This one has the vagus nerve. So go through these tables and summarize all that we do on the recordings and the study questions, and you'll be good. I mean, you're almost there. So it's like a week, and it's all done. So you can do well. This is really good, showing the difference between parasympathetic and sympathetic effects. It's not easy. Once you get past that whole cholinergic, adrenergic thing, this is kind of easier because you know what each does, like the rest and digest versus fight or flight. And that's really basic. Now we've gone a lot further than that. So you should be able to talk about these things. Some problems with the autonomic nervous system, it can be damaged, right? And it seems like diabetes mellitus, which is a problem with your increase in blood sugar, because in type 1, you just don't have any insulin. Type 2, you just can't use the insulin. So you have very high blood glucose, and that damages nerves. And that's what happens, right? damages nerves. So you don't have sympathetic or parasympathetic tone. So you have signs like sexual dysfunction, right? And of course, all the CNS symptoms like dizziness, right? Urinary incontinence, of course, because you can't control. There's no control. Your eyes move a little bit slower and react to light. Sweating is an issue, right? So diabetic neuropathy, uncontrolled diabetes. If you're on insulin, you should be okay with this. As long as you control it, you won't have a diabetic neuropathy that expresses itself in these horrible conditions or horrible signs and symptoms. You know, that's what they are, signs and symptoms. So again, best way to prevent it is to keep it under control with what you eat and the use of insulin if you're type 1, and the use of things like metformin if you're type 2 diabetic. Okay? Control, mostly brainstem, autonomic nervous system. All right, spinal cord is the output. Hypothalamus has control of just about everything. Cerebral cortex is more what you're thinking, all right? How your brain gets in the way of some autonomic conditions. And I would put the limbic system up here. We know the limbic system is part of your emotional brain that involves the amygdala, the hippocampus, the insula, the anterior cingulate gyrus, and of course the hypothalamus, right? Emotional part of your brain. So there is unconscious, and this says right there, limbic system involved directly with the hypothalamus, which is really about maintaining homeostasis. So that's how all this could work together. So the brainstem is most of the direct influence over the ANS. Now you'll learn in AMP2 that the medulla oblongata has an area for cardio-acceleratory, cardio-inhibitory, your respiratory centers, all the reflexes like hiccuping and vomiting, coughing, all are based out of control of the medulla oblongata subconsciously. So that's part of the brainstem, as you know. The medulla oblongata is probably the most, of the brainstem anyways, the most homeostatic control, in conjunction with the hypothalamus, of course. Again, you know this, but you have emotional response now that creates sympathetic. So again, you'll learn about hormones, but usually when you're under great emotional stress or post-traumatic stress or stress initially, the first thing is you go into fight or flight. And then fight or flight is quick, right? And then the second thing is the hormonal release. But let's say you go through this emotional stress day after day after day after day, and it becomes post-traumatic stress or something really horrible happened, then your limbic system will get involved with rage, fear, and sometimes pleasure. Depends on what, but most of it's about this stress. So emotional responses can be pleasure or fear. So it has to do with the signals between the limbic system and the hypothalamus. It usually starts with the initial fight or flight and then more hormonal release. Remember, norepinephrine, fight or flight, nervous system is very quick, short-lived, where the hormonal is long. And there's another hormone which you'll learn about called cortisol, which is released from your adrenal cortex, which is part of an anti-inflammatory response or stress response, but it can affect your body overall, and you're going to learn that in AMP2. I'm not talking about the adrenal cortex here. I'm talking about the cerebral cortex here, because there's connections between the cerebral cortex, which is voluntary and cognitive, that can be affected by the limbic system, right? And voluntary control of some visceral activities. Now, this is hard to do. I think meditation, biofeedback are the only ways to do that. Deep breathing, mindfulness, all those kind of things. Naturally, if you're not taking medications, you don't want to take medications because they have side effects and they change and antagonistically help make your sympathetic or parasympathetic tone go off. So again, biofeedback is basically ways to use mindfulness and awareness to control some of the outcomes. So I would put meditation in there, breathing, right? Yoga, yoga, right? Italian yoga instructor. So this is just showing the connections. You know all these parts. Cerebral cortex is about volition and cognition. The limbic system is about emotional. Hypothalamus is the boss, overall integration, the boss, like President Iacono of County College of Morris, or Bruce Springsteen, the boss. So that has control over, look, the limbic system, which could affect your cerebral cortex, and look at the arrows going back and forth. And the brainstem, which includes the medulla oblongata, has a lot of centers for heart and sympathetic and parasympathetic output and reflexes through the spinal cord. So you're talking about autonomic, so this is not somatic anymore. Yeah, so again, we talk about hypertension, and this usually is too much sympathetic vasoconstriction because the alpha adrenergic receptors are on the smooth muscle in your blood vessel walls. So you can treat that with adrenergic blocking drugs, alpha adrenergic or beta adrenergic blockers. Beta blockers or alpha blockers, I guess. But to tell you the truth, the beta blockers work for both, even though there's alpha adrenergic receptors on the smooth muscle. There's no parasympathetic. So that's control of blood pressure through the ANS. Raynaud's, you may have heard of, is a lack of CNS. So usually it affects the blood vessels, especially in extremities like the arms or hands, where you feel like your hands are very cold. They don't get good blood supply because the constriction is a hyperconstriction of the blood vessels, because there's a dysreflexia, which is really Raynaud's too. So your fingers get blue. Cyanosis means blue due to lack of oxygen. And it's painful too. It runs in families, and when it's cold out, it's much worse. Painful vasoconstriction in your fingers and hands. Sometimes it's positional too. So dysreflexia is just a massive amount of the problems with the autonomic nervous system, especially the sympathetic output. You know, people with spinal cord injuries, of course, have an injury to their autonomic nervous system, which would be a pathological outcome. So your blood pressure can get out of control, right, and almost untreatable. And then your risk, of course, for a stroke, stroke is a cerebrovascular accident where a blood vessel will actually distend and maybe even rupture and hemorrhage, causing death of the brain tissue, which is a stroke from excessive blood disease. So this is Raynaud's. People may have seen this. Some people have seen this a lot. So this kind of like no blood getting to the extremity, and sometimes not even cold. So you have good perfusion of blood to most of the hand, and this can go all the way up the arm in cases of severe Raynaud's disease, which is a problem with too much vasoconstriction due to a problem in your sympathetic nervous system output, excess. Yeah. So as you get older, of course, it declines. So you might get colder easier. Your effect of your PNS or your parasympathetic nervous system, you get a little more difficulty with the defecation reflex, so constipation, decreased fluid production, lacrimation decreases, again, part of aging. Doesn't have to happen, though. There's ways to stop it. Orthostatic hypotension is kind of what I was referring to before, where like when you get up from a seated position, your blood pressure can't keep up with the change in position. Like you go against gravity. Like if you're sitting down and get up, your blood pressure may drop when it's supposed to go up. And that could happen when you get older. So you get a little bit dizzy and you might get that syncope. Because and it's not completely pathological, but you just got to be careful. But the receptors for pressure in your arteries aren't as responsive. So they don't elicit the sympathetic response as quickly as they should. So watch grandma when she gets out of the chair, especially if she's been sitting down for a long time. She may, face plant into the linoleum. So be careful.